It's 8 o'clock.
Okay. Sunilji, can we go live? Sunilji?
Now we can, sir.
Yeah. So good evening, friends, and welcome to this All India Online Postgraduate Teaching Program, which was an initiative from AIS ARC new team. This is the 39th episode. We have been having multiple postgraduate teaching programs over last few years. But this is a PG program with small difference. We look at OSCEs. In certain cases, we also have case presentations and journal clubs. We rarely have once in 4 weeks, we have a didactic lecture. Usually in this didactic lectures, we have a topics which are not comprehensively available for a postgraduate at a single go in a single chapter. So today's topic is going to be an ocular aesthetics, which had been a long question in one of the DNB MS finals. And it's our privilege to have Dr. Aditi Mehta, who will be speaking about this particular topic. And without much ado, I would request our member ARC East, Dr. Kasturi Bhattacharjee, who is a pioneer in our country on ocular aesthetics, to carry forward this particular program and introduce rest of the guests as well.
Thank you, Dr. Prashant. It's a really great privilege and honor to be in this session, especially with Dr. Aditi being the speaker and Dr. E.R. Mohan being one of the panelists, along with Dr. Raman and Dr. Richa. And today we have seen that ocular aesthetic has gone a long way, and we see so many oculoplastic surgeons and so many ophthalmologists are taking this as a frontline practice. So it's very nice. I'm really thankful to AIS, ARC, especially Dr. Prashant, for having this topic for the postgraduate. And we are really looking forward to listen to Dr. Aditi.
Thank you so much,
Aditi,
ma'am.
you can share.
Thank you, Dr. Bamakule, sir, for this opportunity. It's a privilege to be on this panel with Dr. Kasturi, Dr. Mohan, Dr. Raman Mittal, and Dr. Richa. And if I was to look back to my MD exam, and if this question on ocular aesthetics had come as a long question, even I would be stumped. But I hope with today's talk, I can make a difference and I can encourage not only to answer the theory well, but also for more residents to take up oculoplasty and aesthetics as a field. So can I start sharing my screen?
Please,
By the time Dr. Aditi shares, let me introduce you Dr. Mohan. Dr. Mohan happens to be a very renowned oculoplastic surgeon. He's practicing in Chennai and he was an ex-consultant at Shankaran Netralaya. And Dr. Raman has a great contribution towards Oculoplastics Association of India. He was always in the executive body and also he was a secretary, Dr. Mohan, of the Oculoplastics Association of India. Then we have Dr. Raman Mittal. I think Raman Mittal needs no introduction. He is a renowned oculoplastic surgeon practicing in Chandigarh. As Aditi rightly mentioned, he is a pioneer oculoplastic surgeon in North India. He was a joint secretary of Oculoplastics Association of India and very much involved with all the cutting trends and technology in oculoplasty. And Dr. Richa is an upcoming oculoplastic surgeon who is practicing in South in Bangalore. So Richa is also doing excellent job and she has got great contributions and good number of publications. So nice to have you with us, Dr. Richa.
So now Richa is back to Nagpur.
Oh, now she is in Nagpur, right?
Yes.
Okay. So Aditi needs no introduction. Already it is written. So Aditi, please go ahead.
So starting with the talk on ocular aesthetics, from peels to plastic surgery. So the realm of oculoplastics, as we know, is quite vast. We have functional disorders, we have the orbit, we have inflammation, we have lacrimal, we have eyelid, and a small part of it now, which is upcoming, is the aesthetic and the anti-aging surgeries. So if we look at it, today's talk is focusing primarily on the periocular aesthetics. Why has this gained so much popularity? These procedures have gained popularity in the past 5 to 7 years. If you look at 2020 data, eyelid surgery along with non-surgical procedures like peel, toxins, and fillers were the top 5 cosmetic procedures worldwide. And in 2022 alone, the main surgeries that were there were the eyelid surgery, the blepharoplasty, as well as the cheek implant and the malar augmentation, which works on the under eye area. Now, why this trend happened? If you look at it, COVID and the masks, all the focus went to this beautiful area, that is the periocular region. And periocular aesthetics has become an essential part for any ophthalmology OPD. A lot of people come in with a lot of concerns, whether you're a retina surgeon, a cataract surgeon, general ophthalmologist. Invariably, in a week, you may have one patient concerned about the dark circles, the hooded eyelids, and you need to have an answer for them. Even if you don't do the procedures, you must be aware about them. So this talk encompasses these procedures. But before we move on to the procedures per se, we need to understand what exactly are the aesthetic changes in this region. So if we look at the periocular changes with aging, where marked signs of aging are there, if you look at this lady, she's elderly, she's in her 60s, and there are a lot of changes on the entire face, with prominent changes being around the eyes. You have the eyelid bags, the statoblephrons. You have the malar mounds and festoons. And together, these form the double convex deformity, which is the under eye bag region. Along with this, if you look, she also seems to have horizontal eyelid laxity. There is definitely dermatochalasis. There's a tear trough, which is a groove between the malar mounds. And then there are periocular loose skin or the rhytidosis. So these changes are quite prominent, and treatment here would not only be aesthetic, but a lot of it would also be functional, and she is more likely to come in for the related problems like eyelid laxity and dermatochalasis. Compared with this, if you look at the younger age group, upper face is one of the first regions to show signs of aging, and the eyes are the aesthetic center of the face. Around the eyes, you can have a lot of changes. You can have flattening of the eyebrow. You can have a little overhanging of the upper eyelid as an early sign of aging. Of course, periocular wrinkles on animation. Tear trough, appearance of an eyelid bag, malar mounds, and of course, pigmentary changes like dark circles and fat bulges can also be there. Here, the aim of treatment would primarily be aesthetic or anti-aging, to make them look fresher and younger rather than to address any functional issues. If you look at the science of aesthetics in general, there are 5 basic principles. Number 1, which is the only scientific evidence to prevent aging, which is sun protection. For the rest of the body, sunscreens are useful. For the eyelid region, you can't really apply sunscreen on the upper lid thin skin. Sunglasses during daytime hours in the outdoors are the essential part of sun protection. Along with this, you have certain devices for direct collagen induction, which includes at-home skincare with multivitamins, retinols, in-office chemical peeling, microneedling, as well as soft tissue fillers and threads, which induce collagen at a subcutaneous and deeper level. The third component is your energy-based devices. They're expensive machines, but they offer a lot of resurfacing, a rejuvenation, along with ultrasonic and radiofrequency skin tightening. The fourth, and which is the workhorse of anybody venturing into the ABCs of aesthetics, is your neuromuscular relaxants, that is the botulinum toxin, the injectable Botox injections. And the gold standard, as always, remains surgery. So this, as a part of the theory answer, I thought this slide would be useful for everyone. If a question does come, these are the topics I would like to cover in my answer. So for non-surgical, you have botulinum toxin, fillers, thread lifting, and skin resurfacing, which includes your chemical peels, platelet-rich plasma, and energy-based devices, including radiofrequency, lasers, intense pulse light, and ultrasound. Amongst the surgical aesthetics, Dr. Raman Mittal rightly pointed out earlier in the day when I was talking with him, as oculoplasty, each and every surgery is aesthetic. Anything we do on the eyes or the face has to have an aesthetic outcome. But for the purpose of the answer, we have the eyelid surgery, including blepharoplasty, as well as secondary reconstructions, which can happen as a delayed repair of fractures, trauma, or other tumors, which the patient is coming for a secondary procedure to make them look better. Another way of classifying is the target area. So if we look at this, it's a 7-layered structure starting from the skin, the superficial subcutaneous tissue, the muscular aponeurotic system, the retaining ligaments, the facial fat pads, the fascia, and then the bones. So over here, we have the procedures which target different area. You have the peels, platelet-rich plasma, microneedling, lasers, IPL, energy devices which target your skin, epidermis, dermis, and the subcute. Then you have the botulinum toxin targeting the muscles, the facial muscles of expression as highlighted in this particular image. Then you have the threads and fillers, which work on collagen induction and enhance the volume as well as the subcutaneous fat area. And then volume augmentation with bony implants, for example, chin implants, malar implants, to improve the surface and the contour of the face, especially in reconstructive surgery. Coming to the first procedure of choice, that's the botulinum toxin. So if we look at it, what exactly is this? It's a toxin which is purified, specialized and injected to cause a neuromuscular relaxation. So botulinum A and B work on the presynaptic terminal of the neuron to reduce the ACH release, acetylcholine, at the voluntary neuromuscular junction, so that the amount of neurotransmitter reduces and therefore the intensity and force of contraction of the muscle comes down, leading to reduction in long-term appearance of coarse and fine lines, and hence delay both dynamic as well as static wrinkles. If we look at the history of botulinum toxin, in 1822, it was identified as a fat poison in different mice. In 1869, systemic toxicity with botulism was discovered by John Miller, but only in 1973 was the first published use of botulinum toxin A, and that too for a functional indication of squint by Scott et al. In 1989, the FDA gave approval for use of botulinum toxin for blepharospasm and strabismus, and in 2002, it gave approval for cosmetic use at glabellar and frown lines. If you look at the type of toxins, you have A, B, C1, D, E, F, and G, out of which A, B, and E have shown activity in humans. And A and B have a long in vivo potency, which means once injected, they will have some duration of action in the body, while E has a fast washout. So in botulinum A, we have different products commercially available. It targets the presynaptic SNAP25 protein, reducing the release of acetylcholine molecule. So we have the Botox, which is by AbbVie, which is the most popular, which contains onabotulinum toxin A. Then you have the Dysport, which is abobotulinum toxin A, Xeomin, which is Inco, and Jivu, which is Prabo. Others include Daxi, Prostagine, Botogene, which are not yet FDA approved. For Botox B, which has been gaining popularity amongst the neurologists, it is the myoblock and the neuroblock, and it seems to work very well for spasms, but it's more expensive. So these pink ones are highlighted as FDA approved, whereas the others are biosimilars. When you develop tolerance to one type of botulinum A product, you can switch the product as the molecular weight and the constitutions are different, or switch from A to B. However, you must remember that the doses are not numerically interchangeable. And to familiarize yourself, stick to Botox first, learn the reconstitution, and once you're familiar with this, you can move on to the other products. Out of these, Botox, Dysport, Xeomin are commercially available in India as well. So some of the indications, the aesthetic indications for Botox, besides the functional of spasm, include the periocular forehead lines, the crow's feet, the under eye jelly rolls, and the lines on the inferior crow's feet. Of course, for these, you can do micro Botox to reduce the pigment and reduce the appearance of fat bags, glabella, which is the frown line, and the bunny lines. This is how I reconstitute botulinum toxin, that is the Botox product. So it must always be brought, it's a delicate molecule, it should always be brought on an ice pack. When you have the vial, check the seal, check the label, check the expiry date and the batch number. Once opened, you must do it under sterile conditions. You take out the vial, again confirm the expiry date and the batch number. You can use preservative-free normal saline to reconstitute. The amount of saline used to reconstitute depends on the usage you want. Now, this particular vial, you see here, I don't press the plunger because this is a vacuum sealed vial. And this will be once I insert the saline syringe, it will imbibe the saline on its own, indicating that the seal has not been broken prior and this is good to use. It's a delicate molecule. Don't shake it, just roll it gently between your hands. The next question that comes is, how much Botox will I need to treat these areas? So different guidelines are available, but in general, for the forehead and the glabella, you need about 30 units each. Crow's feet, about 10 units per side. For the bunny lines, it's about 5 to 8 units. For other indications, because if you're treating this area, you're likely to treat the lower face as well. For the neck, you have about 10 units per side. For masseter, about 30 units. And then you have the chin and the angles of the mouth, which work with very low dose, 2 to 4 units each. The next step is local anesthesia, which I use prilocaine cream, Prilox, just this topical EMLA mixture. And I have to be careful when applying it in spasm patients around the eyes because they keep blinking and there's a risk of the cream going inside the eyes. But with an earbud, you can gently apply it on the other areas. After that, in the beginning, you must always mark. So over here, if you notice, I'm marking the pupillary center. When we are injecting botulinum for spasm patients like this patient, you will be injecting the entire upper lid, the medial and the lateral part because you want to have a good effect. But when you're targeting the aesthetic patients, do not cross the pupillary plane and go medial to it because otherwise then risk of epiphora and other complications can happen. You can ask the patient to animate so you can do your markings correctly. You can ask them to frown to mark your glabellar region, that's the procerus and the corrugators. You can ask them to elevate their forehead to mark the forehead lines if you want to. And this serves as a good guide when you're starting out your injection. You should have your points decided. A precaution that you take is because these markings are there, you have to do the sterilization again with an alcohol swab. And once you have sterilized again, while injecting, avoid directly onto the mark and go by the side of it, else you will be seeding the ink into the injection site. So after this, you start injecting. So this is a patient of spasm where I'm injecting in the upper eyelid. And if you notice, it's a thin skin and I'm deliberately forming some blebs. Even in the bunny lines, I'm forming a bleb because I want my Botox to remain in the subcutaneous muscular plane and not go too deep inside. The upper eyelid is a multi-layered structure. If it goes too deep in the LPS, it will cause ptosis. Do not worry if a complication happens because the molecule is short-lasting. This particular product has a duration of action of about 3 months. Any complication that happens, as long as you have counseled the patient beforehand, it will go away. It will be completely reversible. Here, if you see, I've placed my finger just beneath the rim so that my corrugator Botox doesn't seep through. This patient is a constant spasm. The minute I'm injecting, she's moving it. Gently, I'm applying the ointment, but the blebs are there, and you have to tell them that they will disappear on their own after 6 to 8 hours. Do not massage them. Some results for the aesthetic Botox treatment from my clinic. You see here the crow's feet, the under eye lines and the jelly rolls have reduced significantly. Again, crow's feet with a very natural appearing contour. And this patient had a wonderful result. This was a combination treatment. I'll be discussing her further in the filler as well. But the Botox has worked very well for the lateral crow's feet and the under eye jelly rolls in her case. Coming to the next, which is chemical peels. So I have gained familiarity with the chemical peels in the past, I would say a year. And a lot of it goes to my dermatologist for being the support for learning this procedure. So chemical peel is a minimally invasive skin resurfacing procedure. It is not a new thing per se, because if you look back at scientific literature and literature in general, from the time of Cleopatra, baths with sour milk which contain lactic acid, a prominent compound in a lot of chemical peels, were done as a part of rejuvenation and to look beautiful. Idea of the peel is to produce a skin remodeling, to cause an improvement in rhytids along with pigmentation and reduce the scar which is there in the skin. The peels are classified. There's a huge table in a lot of dermatology books as to what is the type of peel, what is the type of acid, whether it needs a neutralizing agent or not, and what's the depth of the peel, which is important to understand as to on what layer will it be acting. For the delicate periocular skin, the peels which are safe include the lactic, the fruit peels, the arginine, ferulic acid, and a very low dose trichloroacetic acid peel, which is 3.75%. The procedure for peeling is such: you need to have your products ready. You need to have a neutralizer ready, which is important in case of any spill, and once you have to wash away the peel. A little bit of the peel is taken, along with the earbud, it's gently applied. Over here, I never put any topical anesthesia in the eyes because if a peel has spilled and if the patient is anesthetized, I'll never get to know. So no paracaine. Be careful while applying. The minute it's applied, you start your timer. So if this is, every peel has its time mentioned. This is a fruit peel, so it can be kept up to 10 minutes, but constantly monitor the patient. If they're saying there's a lot of stinging or burning sensation, use a neutralizer, wash away the peel, and give them a cooling mask in the end to get a comfortable result. This is after 10 minutes, the peel is done. We are washing it off. And then you can give a cooling mask if the patient wants so that they feel comfortable after it. Mind you, the peel does produce a burning and pricking sensation. It is not an overnight treatment. You need multiple sittings, 6 to 8 sittings, and then annual maintenance doses. And these should be repeated at a gap of 6 to 8 weeks to allow the skin to regenerate. Some results with the peeling. So this patient underwent a high-dose salicylic for the acne marks on the forehead, where the baseline pigmentation has reduced after 3 sittings, and some marks have completely disappeared. But it's an active acne, so she's getting new marks and she needs to peel again. Along with this, we did a fruit peel for the under eye area and the upper eyelid. And if you look here, the junction between the eyelid and the cheek, the pigmentary changes have disappeared, and now it's looking more smooth and one color. Deep phenol peel. So this is taken from the American Academy of Ophthalmology. They have a lot of resources. I have no experience with this because these are only approved in the fair skin. That's Fitzpatrick 1 and 2. That's the Caucasian white skin people. So if you look at this particular patient, the before and after, it seems as if she's actually undergone a blepharoplasty. But no, all of this has been achieved with a controlled chemical peel using a strong peeling agent, that's phenol and croton. To know more about this, you can refer to these resources on the American Academy of Ophthalmology. But I personally, in the population I work on, I have no experience on these. Coming to the platelet-rich plasma and the microneedling. So this is utilization of the body's own growth factors to induce changes for improving the aesthetic appearance. It can be combined with growth factor concentrates when they are called exosomes. And the basic equipment require, of course, the vials, the centrifuge machine, the syringes, and you may require a microneedling device. So this is how a PRP setup looks like. And this is a derma pen that I use for the microneedling. Once the blood is taken in your serum vials, it's centrifuged, and then the plasma is separated and loaded onto the syringes. You can either use 30 gauge needle to inject this, or you can pour the plasma and use a microneedling device. And this is very useful for the under eye area and also on the forehead. But on the upper eyelid skin, I would not recommend using injectable or microneedling because the skin is very thin and the patient it's a painful procedure. You give local anesthesia. Remainder can also be injected in the forehead where there's balding patches for improving the hair growth. And this is an additional use of the PRP. So coming to the soft tissue fillers. So filler is a substance which is going to fill a space. That's a very logical thing. The most common is the similar from the biological compound, that's your hyaluronic acid, which is found in your joints, in your skin. It's an important component of all the basement membranes. So this has been purified, isolated, and cross-linked to produce a molecule, which is a biological product, that is the filler, which acts to augment the volume, induce collagen production, and has a limited reversible life of about 18 to 24 months, depending on the amount of cross-linking. The other fillers which can be semi-permanent include the calcium hydroxyapatite, polylactic acid, which is semi-permanent because it induces some kind of permanent scarring and collagen production, and polymethacrylate, which is permanent. The permanent fillers are not so popular anymore because being irreversible in nature, if things go wrong, it's very difficult to get rid of them and you need to surgically excise them if there's some kind of a complication. The most natural filler is the autologous fat, which can be harvested from the abdomen, can be prepared into nanofat and injected. However, it's an unpredictable filler. The amount you give, what part of it gets absorbed, what part of it hypertrophies, what part atrophies is a little difficult to predict, and it can cause a lumpy, bumpy appearance in the delicate under eye area. So the main indication for fillers as part of aesthetics include the tear trough, which can be mild, just seen as a little bit dark circle and a separation in the middle area. You can have it moderate with a little bit of fat bag herniation over here, as noted here in the dark circles, or significant where there is fat bag herniation as well as a deep tear trough. Now, ideally in this situation, this patient will benefit from filler and a little bit of Botox, and this patient should ideally be undergoing a blepharoplasty. But because the downtime is long and everybody is not willing for taking so much time off, they may try with fillers to give an aesthetic outcome. So what does the filler tray look like? So if you look here, this is the product. This is the Volbella juvidum product. This is the filler. This is the cannula. And important here in the corner is this hyaluronidase. So this is a filler dissolving agent. If things go wrong, you should have this ready on the tray when you're doing your filler procedure. So once the patient is prepared with prilocaine, you mark your areas. And I'm very grateful for these videos because aesthetic patients do not let you take photographs, but these are few of my friends and my colleagues at the clinic who are trusting enough to undergo the procedure and have allowed me to take some videos for the talk. So really grateful to them. I would request you not to share these further and use them only for your knowledge. So over here, I'm injecting in the malar area in the cheek point, the prominent CK3 point, to produce a tightening, horizontal tightening. And then I go in the tear trough area. In the lateral tear trough, I'm able to go with the needle. Before injecting, I always aspirate to prevent any intravascular occlusion event, which can be catastrophic. From here, if it goes retrograde, it can go all the way to the ophthalmic artery and cause a CRAO. Now, for the medial part, I'm going with the cannula. But again, I will be aspirating in the cannula first before I start injecting. And over here, I'll be visualizing the appearance of the filler and improvement in my contour while injecting it to decide what amount of filler I need to give. So this patient who I said was ideally a candidate for surgery, but she also had another indication, that is a scar over here, a depressed scar. And we decided to subsize this with the filler, again an aesthetic indication. And since we had some filler left, we decided to treat the tear trough as well. So over here, if you look, she had a post-traumatic scar causing a skin dimpling. So the first process is releasing the scar with the help of a 26-gauge needle, which is a subcision of the scar, releasing the tough fibrous bands between the skin, which is causing the puckering. This is done under local anesthesia lignocaine injection. After this, I'm using a low G' filler to rejuvenate the surrounding skin and provide a hydration effect and give it a collagen boost. The extra product can be used on the other side. Then in the second sitting, I'm injecting a volume enhancing filler product beneath the scar area so that it's lifted and it's no longer causing any puckering, as can be seen beautifully over here, with the excellent aesthetic outcome and a shiny, rejuvenated, aesthetically pleasant skin. So this is her before with the puckering here, and this is her after the subcision and low G' and high G' filler. And this is the other patient who underwent cheek treatment and under eye treatment with a rejuvenated look after 3 months. Another filler which has been done for this patient. If you see here, after the marking is done, she is undergoing the cheek treatment, and this is her before and this is her after. Over here, she looks tired, and here she looks absolutely rejuvenated. So I mentioned the hyaluronidase, which should be there on your tray, because fillers can go intravascularly even despite aspiration and all prevention. You must have your backup ready, your crash cart. So you should have vasodilators, you should have hyaluronidase. You need about 150 to 200 international units per ml of injected filler, along with this vigorous massage and monitoring. So yes, aesthetic procedures are popular, but you should be prepared about these. Coming to the thread lift. So threads are, again, they are what we use as sutures which are semi-permanent, and they have additional property of barbing or rough surfaces, so that once they are placed, they kind of induce collagen and they have a tightening and lifting effect. So depending on the product, you have the polydioxone, polylactic acid, and the polycaprolactone. In the periocular region, they are very popular for eyebrow lift, where they can be injected from subbrow or from the forehead to produce a elevated eyebrow effect. Coming to the energy-based devices, so I do have the M22 IPL machine, which I use for extensively in my dry eye clinic, as well as for photofacial and facial rejuvenation, as well as telangiectasias. And this is one patient who had rosacea, MGD, as well as pigmentary changes. And after 2 sittings of IPL, there's a dramatic improvement. This is actually the case which got me interested in IPL in itself. And I think it's a very useful tool, but you need to know the settings. You need to know what to operate, how to do it, and take all precautions. See, even though it's not a laser, it's an intense pulse light, I am wearing protective eyewear because I'm an ophthalmologist. And for me, I know how important vision can be. I do not have many of the high-end lasers, but what is available in the market, you have the diode laser, which is commonly used for hair removal and can also be used for pigments and telangiectasias with different filters. You have the ablative and hybrid lasers, which can be used for moderate wrinkles. You have, of course, the fractional lasers, which is popularly used for the laser blepharoplasty, which is targets the lower eyelid saggy skin and the facial texture. And you have the erbium YAG resurfacing laser, which is very useful for the perioral rhytids. And coming to the gold standard, that's your blepharoplasty. So every eye bag has its own characteristic. You may have xanthelasmas, you may have mild bags, you may have prominent bags. And whenever you're evaluating this patient, you must always assess for functional issues like eyelid laxity. And you can see here with the eyelid retraction or the punctal eversion. Evaluate in all three gazes, up gaze, straight and down gaze, to look for any hidden ptosis before planning the surgery. And of course, take a history of prior and ongoing aesthetic treatment. Like this patient came in and then 3 weeks later, she came in like this and she's like, I got a filler done for the left eye, it's good. Please remove this bag which is remaining. Ask for old photo scans, because when you're counseling this patient, you need to understand what their realistic expectation is, what they looked like before, any pre-existing asymmetries, and then go ahead with the planning of procedure. Marking has to be detailed. For the upper eyelid especially, you have to mark in the sitting position. The lower eyelid skin excision, you can mark in the laying down position intraoperatively, but before you give the anesthesia. So coming to the surgical step, the first step is marking. Upper eyelid blepharoplasty, this is the most important step. Whether you want to do a skin-only incision, skin plus fat removal, extended blepharoplasty, what your plan is. And always be wary that you need to have a ruler in mind, and the rule of 20. A residual 20 millimeter skin should be left between the eyebrow and the eyelid margin to prevent any lag of thalamus postoperatively. So coming to the procedure, marking is always done in the sitting position. Then the infiltration is done. I use the 15-degree blade, or you can also use the monopolar cautery. After the skin incision, the strip of orbicularis is removed and the skin is closed with a Prolene suture. In case of extensive medial bags, you can also remove the medial fat pad and the central fat pad and redrape it. After that, you can do a closure, which can either be interrupted or continuous. In this patient, she had prominent xanthelasmas. I use that skin to correct the xanthelasma and also do a transconjunctival approach for the lower eyelid fat bags. So this is a scarless approach when you're going for it. And once your septum is opened, you identify the central, tease it out. The lateral fat pad is deep. You have to excise it. The central and the medial, you must identify the inferior oblique muscle and preserve it. Like over here, it can be seen here. And then the fat is excised and the incision is closed with interrupted vital sutures with excellent outcome. So coming to the third, which is a transcutaneous lower lid blepharoplasty, I find it very useful when I have to address eyelid laxity along with it. So once your traction suture is placed on the through the meibomian gland orifices, you make a very superficial incision in the subciliary plane, which is a skin-only incision, because you don't want to disturb the pretarsal orbicularis. If you do that, there's a chance of eyelid retraction and ectropion post-surgery. So I'm here first using the cautery to stretch the skin and gently mark my incision point, and then I go using the spreading technique, very gently make an incision just on the skin, and the orbicularis is not touched at all. The dissection is very gentle. Then I use a straight scissors to further take my skin. You can see how crepey the skin is and how superficial I'm remaining without disturbing the orbicularis. Once the incision is made and the inferior tarsal border is identified, then I can venture deep into the preseptal and orbital orbicularis as required. So the next step is to enter the preseptal plane. And again, a combination of blunt and sharp dissection is used. This area is vascular, the orbicularis bleeds, the patients are old, they're sometimes on blood thinners, so those precautions have to be taken. So if you look here, this is the pretarsal orbicularis, which is left undisturbed. Then you have the preseptal, and then you have the orbital orbicularis oculi muscle. It's in the preseptal that I'll be giving my eventual incision to reach the orbital septum and then the fat bags. The orbital rim should be palpated, especially if you're planning to redrape the fat along the rim to efface the midface and the lower lid cheek junction. And a blunt dissection is done to open the preseptal orbicularis oculi. The next step is tackling the fat, whether you want to keep it or excise it. So once the septum is opened, you can give gentle pressure on the globe to identify, tease out the fat. The lateral fat pad, like I said, is deep. You need to access it and excise it. The central can be partially excised and partially redraped. Similarly, with the medial, you can excise some of it. And what we call it now, the terminology is sculpt. You don't really remove all the fat. You take out some of it, and the remaining you suture along the orbital rim to efface it and to provide a smooth, rejuvenated lower eyelid region. After this, the skin is, the orbicularis oculi is closed, and then the skin is redraped. Any eyelid laxity over here at this stage can be addressed. You can do a simple Bix procedure, which is very convenient. You can do a lateral tarsal strip if required to address the laxity. Once this is done, you can notice the horizontal eyelid tightening, which is required to provide a beneficial effect in cases of functional as well as aesthetic outcome. And then the last part is skin redraping. In the weakest of cases, with the loosest of skin, I'll probably be excising only about 1.5 millimeters, and more so laterally. If I excise too much, there's always a risk of eyelid retraction, and nobody wants that when you're doing an aesthetic surgery. Even when you're doing a functional surgery, that is something which you definitely don't want. And this is how it is at the end of surgery with the upper and lower eyelid blepharoplasty, which has been done. The scar in the transcutaneous also remains hidden in the subciliary region. So, of course, some complications can happen more often with the lower lid transcutaneous approach. Expected are ecchymosis, edema, chemosis, which are going to be there temporarily. Patient may develop allergic reaction to the vicryl sutures used in the transconjunctival approach, and you should be cautious. If you've missed out on a preoperative dry eye and blepharospasm, the patient is not going to be happy after your surgery. And the most dreaded complication is the lower eyelid retraction, especially in aesthetic patients. Some before-after results where the patients have come up and at the long-term follow-up are quite happy with their. This is a patient of blepharochalasis. I was brave enough to try this in my early days of practice. And of course, it's a recurring problem. Immediately, the result is good. It's standing there at 1 year as well. But because it's an ongoing allergy and inflammation, she may come back for further tightening eventually. This is the patient quad bleph with xanthelasma excision, and this is how she looks at about 8 months follow-up. The xanthelasmas are gone. Mild eyelid laxity is there. Bags are completely dissipated, and she is very happy. Along with this, she underwent an MMCR along with the upper lid bleph to have a better eyelid opening. This is another patient whose main concern was that she cannot watch the television comfortably because her eyelids are heavy. She has to lift her frontalis. She is elderly, 80 plus, and this is her after the surgery. So if you look at the before and after over here, you can't even see the upper eyelid margin. But here after surgery, she looks fresher. She looks natural, and her complaint of being able to watch the TV without lifting her forehead has completely gone. Last part of my talk is on aesthetic reconstructions. Like I said, every oculoplasty surgery is an aesthetic surgery. You want to have minimum scar. So sometimes these patients come to you with just small lesions which are near the eye. So these comedones, everywhere else on the face, the dermatologist had treated. Near the eye, he got scared and he sent it to the ophthalmologist. So as the oculoplasty surgeon, you should be aware how to tackle these. So under local anesthesia, you take a monopolar cautery and make an opening in them. For the lower lid one, which is near the puncta, I preferred to use the lacrimal probe just to protect it. And at the end of the procedure, I did a check syringing so that the patient is also satisfied that things are looking fine. And this is how she is after the surgery. They're completely gone, and the scarring will be minimal in this region. Lid margin nevus, this patient underwent a shave biopsy. You have to be very careful and give a very aesthetic result. There should be no loss of cilia, no pigmentary changes, no disturbance to the eyelid margin, and the patient should be aesthetically very happy. That's the aim we go for. Trauma is often challenging. Many times the patient will come for a secondary reconstruction. So when the term secondary comes in, they want an aesthetic outcome. They want to look better. They've already suffered so much mental agony as to, for this patient, she lost her eye. So this is an artificial eye. And there's so much agony. There's deep superior sulcus deformity. So she underwent a dermis fat graft. And there was a reasonably aesthetic outcome, which is due for another volume augmentation along the roof of the orbit. Another young patient, he underwent trauma and had a secondary lacrimal duct obstruction as well. So combined approach, transconjunctival as well as calval loop was done, and the nasal septal cartilage was harvested because we were anyway opening the nasal cavity for the DCR. And this is how he is after the surgery, aesthetically very happy, and the enophthalmos has reduced and improved almost completely, and his DCR is also done, so there's no longer any watering. So these reconstructions are very important. Now, this patient I want to really highlight. This is how he came to me. I did my surgery. I was very happy at 6 weeks that I have managed to save the eye from any kind of scarring, any kind of ectropion being formed. No, there's no lag of ophthalmos, but this scar was there, and I decided to give some tricot injections. So 3 injections, 1 month apart. Things are looking fine, but still pigmentary changes are there. Now, what do I do next? So triamcinolone is done. What next? So we used the dermatology armamentarium. We used a hydroquinone, tretinoin, and steroid cream, basically. And this is how he is at 42 weeks. And he's probably forgotten that he underwent the trauma. You have to show him the picture to remind him from where he's come here. And just a faint scar. And I don't think I could have achieved this by any kind of scar revision or secondary surgery here. It is the role of these creams, topical creams, and knowing how to use them, which is the part of the aesthetics, to get fabulous results and make the patient happy with minimally invasive procedures. And even the little bit of scarring that was there has completely gone, and the eyelid contour is absolutely fine. There's no functional limitation, and aesthetic outcome is quite great. So to summarize my talk, non-surgical procedures, of course, have a less downtime and faster recovery. Most of them are require repeated procedures. They're quite reliable, and in almost all situations, they're very much reversible. But the patient selection is key, and a combination can always be offered. A prerequisite when starting aesthetics is having basic dermatological evaluation skills, and you should always ask your colleagues in the beginning for any cross-referrals that you want. When the patient has certain functional issues like eyelid laxity and bags are excessive, you know there's a limitation to what you can achieve with the filler and Botox, you must counsel for surgery and let the patient decide what he wants and tell them that eventually you may require the surgery. When secondary management and a reconstruction patient comes after having undergone some kind of a repair for any trauma, your focus on aesthetics should be enhanced, because that not only improves the way they look, it really goes a lot in improving the way they feel. Knowing all these procedures is a part of the aesthetic skill set. You don't have to buy all the equipment in the first go. Start small, start with Botox if you're venturing out into aesthetics, but eventually you will need to have some of these devices to have a comprehensive aesthetic practice. And lastly, you cannot really separate aesthetics from oculoplastic surgery. Thank you very much for your kind attention, and any queries and discussion, I think I'll open this for the forum.
Excellent presentation, Aditi. Any questions for Dr. Aditi? Like Dr. Raman, do you have the questions with you? Any one of you?
I would
Yeah.
say that Aditi has done a very comprehensive, for PGs, of course, it is very, very important that she has very nicely, first of all, classified all the aesthetic procedures and the indications into non-surgical and surgical thing. And she has very nicely taken the trip down this aesthetic line. And only thing which I would like to add on is the initial part of her talk in which Botox she has mentioned. The Botox, what the kids or the PGs would like to know is not how to give, mainly maybe now, but also how to prepare the dilution, the time effect that it's temporary, the indications, whether it is therapeutic or aesthetics, and both of them to be mixed in a sync. And Botox can be given along with fillers, which is very important. So they can go from Botox towards fillers, then the peels, and then the surgical steps, which she has very nicely done. To add on to this, probably the lasers, which can help to reduce the scars which are formed after the surgeries. Like in the last case of trauma, apart from the cream which she has used, she could have done some laser ablation for revision of scars, CO2 lasers and all. Overall, a wonderful presentation, and I couldn't have imagined a better one in this time span, covering all the aspects. Congratulations, Aditi. Thank you very much, Kasturi.
Thank you so much, sir.
Thank you, Dr. Raman. Dr. Mohan, would you like to add something?
Yes. Yeah, I'll certainly compliment Dr. Aditi for a very, very nice talk. It's very practical. I think we've had a lot of talks, and most of the talks in aesthetics tend to be quite practical, because very practical field. If you don't do it properly, you don't get the results. So there's, but still, this stood out as a very practical, talk, which is full of tips, which I'm sure all of us will find useful. And the couple of things that I wanted to actually emphasize are that, I think Aditi also emphasized that she is basically not separating aesthetics from the rest of oculoplastic surgery, which is something which I really agree to. Every single student who listens to this or a practitioner will gain from this, because there has to be an awareness of the aesthetic part in functional surgery. I think that's very important. And what can be done for these patients, even if they themselves are not going to do it, to refer, to point out, to use your colleagues' expertise. And also the awareness part, I think that's very, very important, though each person who listens to this talk may not go on to do many of these things. Couple of things which I wanted, if Aditi could speak upon or dilate upon is, how is the identification and counseling of a cosmetic or aesthetic patient different from a routine oculoplastic surgeon? Let's say, how is aesthetic surgery, when you're going to do aesthetic surgery or a procedure, how is the identification of the patient or identification of even red flags and counseling different from what we are used to in, let's say, cataract surgery or in, trauma surgery or in onco surgery? So if Aditi could spend some time, a little bit of time on that part.
So that's a very, very important point raised, sir, because when we are dealing as doctors, we are dealing with disease and patients. As aestheticians, we are usually dealing with normal people who just want to look better, who want to feel better. So the art of counseling is very important. Yes, it takes time to build an aesthetic practice. The first and foremost, I think, would be that you have to give them a feeling that whatever they're discussing one-on-one with you, there's a feeling of privacy. That's why all the photos I use, they've taken consent, and you really have to make them feel that whatever procedure they're getting it done from you, whatever concern they're sharing, it will not go outside that room. I think Kasturi ma'am, when I was a fellow with her, she very well highlighted this. She segregated her oculoplasty OPD from the aesthetic OPD altogether. Physically, the location was changed. So, which is something which really goes a long way in making the, I would say, I won't use the term patient, but the person feel more comfortable. And yes, certain red flags, that's a term that you've used very prominently. So if I will have a patient, a person who's coming in asking me my opinion for what can I do to make them better, that's the usual question they ask. Yeah, I'm like this, can you do something to make me feel better? And in the process, when I'm telling them the different procedures, they'll name XYZ doctor in the region who's offered them this, they've heard bad things. If they're not speaking positively about the other people in the field, and realizing while talking to them that they are probably more of a subconscious need rather than an actual physical need for any procedure, I would hold on. I would do something which is very minimally invasive, if at all I have to do it. Something which is reversible, which of course, like botulinum toxin, is a very rewarding and a very reversible, in the sense it's short-lived, 3 to 6 months, depending on the product used, it will wash off. And build up very slowly, and not be scared to say no. I will say that no, sorry, I don't think I can do this for you. Refer them to a dermatologist or another colleague. Sometimes refer them for counseling as well. But it's a very delicate topic, and you have to give chair time. So I think a cataract patient can be evaluated minus the dilation in about 7 minutes by the expert cataract surgeons. And I would, on an average, spend about 25 to 30 minutes for an aesthetic patient in the OPD. And there's a high chance they go away without getting anything done. But that is how the approach is. So I hope that answers.
That was really very wonderful and very truthful. Like you really spoke out from your heart, and it's really delicate. But one thing I'd like to mention, that we should be a little careful for those patients who have some amount of body dysmorphism. Like those are the patients who are very demanding. So that is very important that at the beginning of counseling and at the beginning of taking up such patient, we should be very careful. But it is always best to tell the patient that when patient wants something, we usually tell them, okay, I'll make you look fresh, I'll make you look happy. Instead of saying that I'll make you look beautiful, I'll make you look young. The common terms that we usually use is, I want you to look more happy, more fresh, and more rejuvenated. So that's really nice to hear from you. And Dr. Richa, you are a young upcoming aesthetic surgeon. So would you like to add some points?
Yes, first of all, I would like to congratulate Dr. Aditi for a wonderfully comprehensive talk. I'm sure all the PGs really benefited from it. I just want to sort of summarize a few points that you mentioned regarding specific to the PG exam, so remembering the anatomy and the anatomy for aesthetics can vary from different planes to different the vertical thirds and the vertical fifths and the horizontal thirds that the face is divided into, the golden ratio, the basic fat pads that you need to know. So, and of course, the muscles that, Botox works on. So many different parts of the anatomy that you need to understand. So at least know the basic things because that can be a part of your answer. And as mentioned by Dr. Bhavan Kohe, if this was an LAQ, I'm sure that would be a part that was expected during the answer. Secondly, the main part of ocular aging, the periocular or facial aging is related to deflation and descent. So these two terms, I think, are a must to be included while mentioning your answer. Thirdly, it is related to every procedure that she mentioned. You must know the basic indications, contraindications, and the complications of every basic procedure, which I think she has highlighted really beautifully. I have a couple of questions for you, Dr. Aditi. So you mentioned about the vascular occlusion and even it may lead to blindness. So for the sake of understanding, can you please highlight on what are the immediate signs and how do you know when to use that hyaluronidase? Secondly, what do you do about aspirin or other blood thinners that the patient is on? How long do you stop them for? And since when you ask the patient to restart it? And third would be, when do you combine surgeries with respect to especially upper eyelid? Would you combine the two like ptosis and bleph, or would you give it as a staged procedure?
Aditi,
Thank you,
would
Dr.
like to
Richa.
take up?
I think the questions are very, very pertinent. So I'll take them one at a time. So regarding the vascular occlusion that we're talking about. So in a sense, these office-based filler procedures should be pain-free. Little discomfort is expected. When you're injecting, aspiration is your friend. Aspirate for longer whenever you have moved your needle a little bit, especially in the tear trough area and the cheek area. But if while injecting you feel the patient is complaining of sudden pain, sharp pain, severe pain, stop and inspect. One of the early signs would be blanching, of course. So pain is a symptom. Pain which is not expected at all. A little discomfort, heaviness, everybody will say. And you can judge the patient while assessing how much of a how much pain to that patient will have. But anything which is sudden and sharp, anything which is causing visible blanching, immediately stop. Hyaluronidase is required. Before injecting hyaluronidase, you have to prepare it, of course. In that much time, immediate vigorous massage should be started. Check the vision. Ask the patient, check the pupil reaction. That's a very subtle indicator. And if there is visible necrosis, so necrosis will actually happen if your occlusion is missed, the symptom is missed, and it will come 24 hours later with darkening of the skin, not at the immediate stage. But that is also the time to hyalase so that you can remove whatever remaining filler is there. And then, of course, give hyperbaric oxygen, vasodilation, and try and manage. If in my hands, touch wood, never say never, but it's not happened so far. But I have dealt with complications of surrounding injectors in the Tri-City. I think a pupil reaction and a dilated fundus examination is very, very important. They usually come to you after the primary management has been done. Hyalase can be further given because the filler, it's not going to go away with one hyalase. You can repeat it after 6 hours and then after 24 hours if required. And don't ignore any symptom of the patient is what I would say as an early sign to pick it up. Coming to aspirin and the other anticoagulants. So
where would you inject hyalase?
So where your filler has been injected in the same region. And if you're suspecting a vascular occlusion which has gone retrobulbary, yes, you would go with your 23 gauge needle, give a retrobulbar along the inferior orbital rim and inject the hyalase. But be careful, Hyalase in itself is a protein. If there's a inflammatory reaction, you may have to do a canthotomy, cantholysis, and you have to be very careful. You can't inject hyalase and send the patient away. Monitoring has to be done almost continuously. So depending,
Aditi, probably
usually in the
what
nasolabial fold where the filler is done, I would inject it there. That's
Dr.
where
Raman?
I did it before. But if it is in the tear trough, I would not hesitate to go retrobulbar with the hyaluronidase.
Aditi, probably what Richa wants to know is probably CRA or the vascular occlusion is because of the filler reaching intravascular areas, right? So, do you want to give hyalase intravascular then?
No, in the surrounding
Because
tissue. You have to remove the surrounding, not intravascular, because then it can go anywhere. And of course, it can disrupt the basement membrane of the vessel itself. You have hyaluronic acid in your body as well. Hyaluronidase specifically works on the cross-linked filler. So if it is a hydroxyapatite or another filler, it's messy. I think ma'am has had experience with the other persons injecting other fillers, permanent fillers, and having problems. The question regarding aspirin, very valid question. So theoretically, 120 days is the cycle of the RBC, and stopping aspirin for 7 days is just for our mental satisfaction and clearing the anesthesia clearance. So if it's a surgical procedure, I'll be going ahead with the coagulogram and I'll rely on what my anesthetist says. Usually I stop 2 to 3 days prior and keep it stopped for 2 to 3 days after the surgery, where the secondary clot is going to retract. And after that, I restart the aspirin. Warfarin, of course, 14 days. And in warfarin patients, your PTI-INR profile has to be repeated along with your liver function test. Since we have brought this topic up, I also refrain them from using ginger and garlic in their food in the postoperative period. And I also stop the vitamin E supplements if they are taking any for about 2 weeks postoperatively. For procedures like filler and Botox, so usually a patient who requires Botox and is on aspirin tends to be the spasm or the functional patient. You just counsel them for the bruising. There is no point stopping aspirin for a week every 3 months. You just tell them कि थोड़ा सा bruise हो सकता है, होगा तो छेड़ना मत, दबाना मत. Otherwise, the Botox will diffuse, and you just ask them to be prepared for it. And of course, you're very careful while injecting. You spread the skin, avoid a vessel when you're injecting so that your needle doesn't go through that. And the third question was on?
No, combination of surgeries, whether you stage it or whether you...
Yes. So in the preoperative evaluation, I mentioned a point that you must always evaluate in all 3 gazes. If I feel that there is a component of mild ptosis in the older population, I'll do a phenylephrine test. And I'll combine the MMCR, the transconjunctival ptosis surgery with the skin approach for blepharoplasty. If there's a significant hollowing, there's a superior sulcus deformity, I feel it's a aponeurotic ptosis and I'm going through the skin side, I may do a levator plication, not a resection. I'll prefer to do a plication in these patients because of the skin excision and the kind of vascularity or opening the septum, removing the fat. I feel plication is a little safer to do. Resecting the muscle, I'm not that very confident because some effect is going to happen with the skin dermatochalasis removal as well. But if a phenylephrine test is positive and it's giving me an adequate result, I will add it with my blepharoplasty. For mild ptosis, that is there.
Thank you, Aditi. You have explained it very well. And so I also agree to whatever points that you have mentioned. Yes, we do blepharoplastic combos. There are lots of indications, especially if you have someone with a blepharochalasis, and we all know blepharochalasis is associated with a lacrimal gland prolapse. So these are the situations where in the same sitting, we do a blepharoplasty along with the correction of the ptosis, along with the repositioning of the lacrimal gland. Secondly, many times we find that the brow is also totic, so we have to do a blepharoplasty along with the brow surgery. Aditi has already mentioned that the phenylephrine test is positive, or sometimes whenever you see a patient coming to you for an ophthalmic evaluation and also for a blepharoplasty, the moment we give the phenylephrine drop, the dilatation drop, we see the eye retracted. So those are the patients where we plan for blepharoplasty. We usually also do a MMCR in such patients. So and also sometimes you see very heavy amount of lateral hooding and the dermatochalasis. Those are the patients we do a extended blepharoplasty along with some amount of lifting, lateral lifting in the form of the brassiere suture or different types of sutures that we use for the lateral lifting for the hoods. So there are different indications for a blepharoplasty combo, and especially for lower lid also. Many times along with the lower lid blepharoplasty, when we see a mid-face ptosis, So we also do a mid-face sleeve. We do a smash sleeve, we do a suit sleeve, or we do a orbic suit sleeve, right? So there are different, and many times we do a lateral cantopexy, a medial cantoplasty, or a lateral cantoplasty. So I feel that in Indian scenario, like because these surgeries are not covered by insurance. So if in one time, whatever possible, if we can correct the maximum number of their deformity or the dysfunction that they have, it is better in Indian scenario, because this we cannot compare with the abroad, because everything is, covered by insurance. Everything is done stage wise. But in India, the scenario is totally different. And Richard slightly mentioned about the 3Ds, the deterioration, descent, and the deflation. These are the main reasons which leads to a negative vector. But because of the paucity of time, I feel that Aditi has not touched the anatomy or the physics and physiology of the aging. So I'll ask Dr. Prashant
It's
to have
9 o'clock.
another class on this physics, physiology, and anatomy regarding the whole of the face, because I feel that the face really belongs to the oculoplastic surgeon. When I was teaching my DNBs, it is very well written there for the oculoplasty. It has written as ophthalmologist doing oculoplastic surgeon. Their domain is from here to here. So all of us must know everything from here to here. And but in a very brief, I'll say the upper part of the face is always sad part of the face. The middle part is always the happiest part of the face, and the lower part is always the sad part. So whenever we do a Botox, you should be very careful that do not touch the middle part of the muscles, because whenever you do a Botox, either functional indication or cosmetic indication, do not go beyond the orbital rim, because in this orbital rim, you also have the origin of the zygomaticus major. And the zygomaticus major, what this does, it lifts the face and also lifts the lip. So if there's any diffusion into the zygomaticus, the lip will also come down, the face will also come down, and this happy face becomes a sad face. So we should always know that one thing, the only elevator of the eyebrow is one muscle frontalis. Rest all depressors of the eyebrows are the four muscles, which is the orbicularis, the posteriors, the corrugators, the depressors. The mid-face leaves are always happy group of muscle, which always lifts the face. And the lower part face, lower muscles are always the sad group of muscle, which pulls the face down. So in a very nutshell, and just letting you all know what is about the anatomy. So thank you very much. It's 9 o'clock. I think I'm really thankful to Dr. Mohan, Dr. Raman, Dr. Richa, Dr. Prashant, and Aditi for a wonderful talk. And I do hope that someday again we catch up and discuss more in details. And I think for the viewers, let me tell you, we have the midterm OPI. This time it is in Chandigarh. It is on 12th. But 11th, we have an aesthetic session. Anyone wants, please do join us physically on 11th at Chandigarh. So thank you very much. And I think should we close it? Dr. Mohan, Dr. Raman. Okay?
Yeah,
Thank
you,
you
Kasturi.
very
That was
much. I think
wonderful.
it was a
Aditi,
wonderful
thank you so
session.
much.
So on
Thank you,
behalf of ARC, I thank each one of you for spending this evening with us. Thank you very much. Bye-bye.